Okay. Yeah, we put it up on our website, Dr. Smith, if that's okay with you.
Oh, absolutely.
Recording in the slides, that's you. And we always we have it on our website, and so we're getting quite a
All of them.
stock of information. So, okay. So those of you who don't know, again, this is Dr. Pam Smith. She was the originator, and I don't know what you call yourself, of the A4M fellowship. She's got 1 million degrees. She's got 400,000 books and papers she's written, and she is my go-to. If I can't figure out something, I'm either on the email or phone trying to find a solution, and she always has very good information. I'm also fortunate that she lives in the same city as my daughter. So my daughter had a problem. I think she came to visit you. She had a fertility problem. So I think she came to visit you at least one time. So, and she had a baby. So there we go. So you can introduce yourself. Go ahead. I'll be quiet.
Oh, thank you very much, Bill. Hi, I'm Dr. Pam Smith. It's great to have you all join us tonight. During the summertime, we are kind of used to a lower attendance in person, but that's wonderful because in the age of electronics, people can watch this at any time. And I'm guilty myself of not always being there in the summertime when I'm watching other people. But for those of you who join us virtually later, that's great as well. Tonight, we're going to spend the next hour or so looking at LDN and rheumatological disorders, specifically rheumatoid arthritis. So just a few minutes about autoimmune diseases. Rheumatoid arthritis is one. I am just beginning now my 44th year of practice. It's hard to believe, but what's even harder to believe is the increase in autoimmune diseases in my own practice time. In 1/3 of the cases of autoimmune diseases to 1/2, depending on the article you're looking at, there is a genetic component. And most autoimmune diseases, or many of them, are more common in women than men and women of childbearing years. The incidence are dramatically increasing in the last few decades. There's, according to this study from 2005, almost 100 autoimmune diseases. The newest numbers are now 105, with chronic Lyme disease joining the group of autoimmune diseases. So 1 in 12 Americans, 1 in 9 women will develop an autoimmune disorder. 1 in 20 people in the US get coronary artery disease. 1 in 14 get cancer. So this means that autoimmune diseases are more common than cancer and heart disease. 24 million Americans are suffering from autoimmune illnesses. You can see some numbers here on lupus, rheumatoid arthritis, more than 2 million people. Sjogren's syndrome, 4 million. Autoimmune diseases are the 8th leading cause of death in women, and autoimmune diseases shorten the average person's life by 15 years. It's also very interesting to look at the economics of it. The yearly healthcare cost of autoimmune diseases is 120 billion with a B dollars. That's just amazing. This compares to 70 billion as a yearly healthcare cost of cancer. So for 2.2 million women are living with breast cancer, 7.2 million women have a coronary artery disease, 9.8 million women have more common autoimmune diseases like lupus, scleroderma, rheumatoid arthritis, MS, inflammatory bowel disease, Sjogren's, or type 1 diabetes. So here's just some stats here. Leading the way is Hashimoto's thyroiditis when we look at the female to male ratios. And actually, the last patient I saw today was someone I was so excited to see. She's the daughter of 2 of my patients, and she just wanted to look at being healthier. And she has Hashimoto's thyroiditis, but she still has normal thyroid function. It's so early. Her thyroid antibody was only 10. So this is someone that actually, in many cases, at least half the time, if people are willing to do some of the things we're going to talk about tonight, they can literally cure the disease if it's early on when it comes to things like Hashimoto's. There's 3 things we do for every autoimmune disease. 3: no gluten, fix the gut, low dose naltrexone. So again, no gluten, fix the gut, low dose naltrexone. So rheumatoid arthritis, as we all know, is a chronic inflammatory autoimmune disease. It affects about 1% of the world's population. The pathogenesis is kind of unclear, but we know there is a genetic component for 50 to 60% of the patients. Autoimmune diseases are not reportable, by the way, so these numbers that we're talking about here may actually be a lot higher. So looking specifically at rheumatoid arthritis, the pathophysiology you all know, so I'm not going to bore you with that. I just included it in this seminar so that we are all on the same page. It is an inflammatory condition. So there is intra-articular inflammation. About 50% of people are partially or completely disabled within 5 years of being diagnosed. So patients who have RA have a higher risk of cardiovascular disease, left ventricular dysfunction, pulmonary hypertension, and first-time acute MI. So higher risk of other diseases as well. And for the diagnosis, 4 of 7 things you have to meet the criterion here for RA. Serological testing for antibodies, the anti-CCP antibodies is available. This is the gold standard. We first of all get rheumatoid factor. If it's positive, then we go on to get an anti-CCP antibody, which has a 67% sensitivity and 95% specificity for RA. It is a multifactorial disease when you look at the etiology, looking at genetics, environmental, immunological issues. They really do all play a role. So hereditary-wise, studies have shown an increased risk of developing the disease in patients that are HLA-DR1 and DR4 subtypes. Environmental factors, smoking. You would think that, of course, for all these years, we know that smoking is problematic. Of course, not everybody is going to get lung cancer that smokes, but most people end up with some lung disease. It does increase the risk of high blood pressure and heart disease, and it increases the risk of macular degeneration significantly. We don't seem to talk about increasing the risk of RA, but it does in people who are genetically predisposed. Believe it or not, 1 billion people in the world still smoke. Poor diet with an increase in sugar and drinking more than 3 cups of coffee a day are risk factors. It's interesting. 1 cup of coffee or tea is fine. 2 cups are fine. When you go to the 3rd, it leaches 45 milligrams of calcium from the body, and it predisposes to osteoporosis. It predisposes to other diseases too, like RA. Moderation is the key to health. When you look at physiological factors such as stress, it does play a role. Honestly, I can't think of any disease where stress doesn't play a role. Silicate exposure can increase the risk of developing RA. That's different kinds of things that are minerals that are in the ground that we look at. And of course, oxidative stress. Patients with the lowest antioxidant status do have an increased risk. We've known this since the late 90s. Microbial influences are becoming an increasing risk factor for many diseases, including RA. One study showed the onset of RA was preceded by an infection in 8 to 15% of the patients. Infections that have been possibly associated with it are Epstein-Barr, cytomegalovirus, parvovirus, rubella, mycoplasma, amoebic diseases, E. coli, Proteus, influenza, and gum disease as well. We commonly talk about what is going on with periodontal disease and infections in the periodontal area when it comes to heart disease. Same bug when we look at rheumatoid arthritis as well. And of course, I love to talk about hormones. Those of you who know me know that it's my favorite thing to talk about. But my probably second or equal favorite thing is to talk about the gut. The patient's gut's not healthy. They're not healthy. And dysbiosis, small intestinal bowel overgrowth, when we look at this, is there a link to RA? There is. The fecal flora is altered in patients with RA. There's less bifidobacteria and less Bacteroides and Prevotella and Porphyromonas as well. And Prevotella does go down, by the way, with age. This study revealed that RA patients, 51% of them had SIBO, and the degree of their SIBO was associated with the severity of the disease. There's also abnormal gut permeability, i.e. leaky gut syndrome. Patients with RA have increased intestinal permeability to antigens and also have alterations in gut flora, which does lead to leaky gut. This increases the translocation of antigens to the remainder of the body. I find this very interesting when I look at the idea of COVID, and all these people get on television, radio, and the internet, and they talk all about this terrible disease process and this terrible bug, but nobody seems to talk about the gut and the immune system. 70% of the immune system is in the GI tract. Here's the periodontal disease. Studies have shown a correlation between RA and periodontal disease. Food reactions. We talk a lot about the gut, but we don't always give credence enough to allergies and food sensitivities. Both gluten and dairy antigens can cause responses similar to bacterial super antigens. So from this study, they tested people for food allergies. You should do the same. If they eat foods they're allergic to, this is a setup for an inflammatory response. One study that's referenced here showed there was a positive correlation between rheumatoid arthritis and food allergies in 20 to 40% of the patients. Xenobiotics. They may be toxic to patients with RA and people at risk for this disease due to impaired metabolization of acetylation pathways. Slow acetylators have almost 5 times a greater risk of developing erosive RA than fast acetylators. And people go, oh, I know my body works perfectly. And the same people tell me, oh, I can't drink a cup of coffee after 12 noon, or I can't go to sleep at night. Those people are probably poor acetylators. And of course, hormone imbalance. Testosterone replacement in males was shown to decrease rheumatoid factor levels, the amount of non-steroidals used, and also the number of affected joints. Elevated TNF-alpha, an inflammatory marker, levels, along with chronic inflammation, increase the conversion of testosterone to estrogen in both men and women by stimulating aromatase activity. And of course, men do make estrogens. It's very important. Men need estrogen for memory. They need it for bone structure. If estrogen is too high, it increases their risk of heart disease and it increases their risk of prostate cancer. We don't want testosterone to be too high in women. Women need testosterone, it's bone strength, sense of well-being. But if testosterone is too high in women, it drives up their blood sugar and increases their risk of heart disease. So hormonal balance is important. So consequently, decreased androgen to estrogen ratio has been seen in both sexes. This is the differential diagnosis of elevated anti-CCP. So an elevated anti-CCP is not diagnostic, but we gave you the actual numbers. It's pretty close. These are other things that the disease process could be as well. And most of these are autoimmune diseases. Conventionally, what do we do for these patients? Traditionally, what we do is we address the inflammatory component, the free radical component that produces joint damage, and we stabilize the immune system. So most people are started on DMARDs. These are drugs that are started within the first 3 months of diagnosis. There is literally a decreased risk of joint erosion. I am a very trained traditional doctor, as are most of you on tonight and people who will hear this webinar later. I never throw away the bathwater when we look at what's going on. I believe in traditional medicine. I just tell people that all of us have a bigger bag of tricks. So some of our patients do end up on traditional medications, but they can have major side effects. Remember, if we can even help them lower the dosage, almost every drug in the world, side effects are dose dependent. Non-steroidals are traditional care, as are these disease-modifying drugs that we mentioned. Here are some listed here. There's biological disease-modifying anti-rheumatic drugs as well. Steroids are still used. Reduction of joint stress is important. And of course, occupational and physical therapy is key. And then some people do end up in surgery. So those are our traditional therapies. What can we do from a more personalized medicine approach? I find it really funny. We had a discussion tonight before we started this webinar on what word we should use to discuss what we all do. Is it integrative? Is it functional? Is it anti-aging? Is it precision medicine? Is it personalized medicine? I honestly wish we would all decide on one term, but you understand when I mean personalized. We want to really look at each patient and what their studies show and look at the cause of the problem and treat the cause. Diet is a key component to a personalized approach in rheumatoid arthritis. Of course, have the patients eat foods that are low glycemic index. If they eat high glycemic index foods, they cause immunosuppression. They promote intestinal bowel overgrowth, dysbiosis, inflammation. Have the patients avoid foods they are allergic to. This contributes to dysbiosis and inflammation as well. Some studies do suggest a vegetarian or vegan diet to improve gut bacteria and increase bacterial diversity. I'm not one of those people that it's actually pro-vegetarian or vegan. If you have MS, absolutely positively, the patient should be a vegetarian or vegan. The Schwank trial has gone on forever. Important. If it's your religious belief or even your personal thought to have a vegetarian or vegan diet, great. There are some studies that show that for patients that have rheumatoid arthritis, this is a better eating program. If the patient is going to be a vegetarian or vegan, then make sure you look at their B vitamin status, etc. And something sometimes I think we forget. A lot of these patients do not get enough protein. So for their entire life, please follow their fasting blood sugar, fasting insulin, and hemoglobin A1C. Unless healthcare providers are in our field, I honestly never see them measure the actual hormone, the fasting insulin. Perfect is 6. Too high or too low is a pre-diabetic state. So fasting insulin is 2. 80 to 85% of those people go on to have insulin resistance and eventual diabetes if they live long enough. Not anti much of anything in the world. Make sure the patients get enough vitamins if they're vegetarian or vegan, and you watch their blood sugar. Short-term fasting can be beneficial. What it does is it deprives intestinal microbes of food that could be bad bacteria. It does stimulate intestinal B cell immunity. It improves bacterial action of neutrophils. It raises the levels of DHEA, anti-inflammatory immunomodulator. Yes, DHEA makes estrogen and testosterone, so we don't suggest people that have prostate or breast cancer take DHEA, but you can raise levels and be very therapeutic by short-term fasting. It reduces lysozyme release and leukotriene formation, and it helps gut permeability. So just make sure the patient gets food before 10 a.m. in the morning. Breakfast really is the most important meal. The patient makes insulin at 10 in the morning. If they don't eat breakfast before then, it does teach insulin to work ineffectively in the body. Same thing in the evening. People make insulin between 5 and 6 p.m. Make sure that they have eaten somewhere around that time and not 9 p.m. That's not beneficial to their blood sugar either. Results of several studies have shown substantial reduction in disease activity in many patients on an anti-inflammatory diet. I personally call this the Mediterranean diet. When people ask me, with their disease, what diet should I be on? Well, honestly, I don't like the words diet. How about healthy eating program? I love Mediterranean because it's anti-inflammatory. And almost any disease people get after the age of 45 is inflammatory in nature. This study is now being done. So this is underway. It was started in 2018. And this study is designed to further determine the efficacy of an anti-inflammatory eating program in people with RA. In this new study that was published in 2020, anti-inflammatory diet is being used in an ongoing pilot study to determine, again, is this going to help with pain and joint swelling in these patients? Avoid gluten. This is a key component. Important to avoid dairy, but really the key is gluten. People get exacerbations of their disease. It should be avoided at all cost. Most studies show these other foods should be avoided as well. You see dairy heads the list. Some people also have problems with nightshades. Not everybody does. So tomato, potato, eggplant, peppers, tobacco. Simple way to determine this. Have the patient stop nightshades, anything from that group of food, for 30 days and see if their symptoms improve. If they do, then they're nightshade sensitive. Have them permanently stop nightshades. Many people, it does not bother. What else can we do beside a better eating program for these patients? Supplements. Yes, it's always great to eat your way into what you should be eating it into, but fatty acid replacement is very important. EPA, DHA, it does usually need to also be taken as a supplement. Yes, fish is great. Lamb, by the way, most of the fat in it is omega-3, but most people do need to take 3,000 milligrams a day. At 4,000 milligrams a day, fish oil does become a blood thinner. So if someone has a blood dyscrasia or they're on a blood thinner, then 4,000 milligrams and above will affect their blood clotting. Also, omega-9 fatty acids like olive oil are very beneficial. You can measure fatty acids. You can do a fatty acid test. GLA at 500 to 4,000. Some studies have shown a benefit, others have not. And different things have been used as borage oil, evening primrose oil, hemp, blackcurrant seed oils. Vitamin D is actually a hormone or poor hormone. I love vitamin D. There is an increased incidence of vitamin D deficiency in all autoimmune diseases, including rheumatoid arthritis. So measure levels and treat appropriately. Vitamin D supports the immune system. It's anti-inflammatory, relieves pain, antidepressant, prevents osteoporosis. It's really huge. As you all know, there are some people that you cannot get therapeutic with vitamin D because calcium goes up, people with sarcoid and other granulomatous diseases, people with hyperparathyroidism, etc. Everybody else, 55 to 80, is really a great location for their vitamin D level to sit. And correct hormone imbalances. Hyperprolactinemia promotes immune stimulation. This can be treated botanically or with a medication. Low DHEA levels, as we mentioned, do a salivary test, determine where is the DHEA level. If it's low, replace it in people who are candidates for DHEA replacement. Decrease may be due to an increase, as we mentioned, in aromatase activity in the synovial tissue of these patients. DHEA is anti-inflammatory. It does regulate the immune system. It inhibits cytokines due to the NF-kappa beta inhibition. Prednisone, by the way, suppresses DHEA. So if the patient's on steroids for a long time, their DHEA level is probably going to be low. It helps with osteoporosis that may be caused by the steroids we've been putting people on. In supraphysiological doses, it's actually the treatment for rheumatoid arthritis and lupus. Here, I'm not talking about hormonal balance for male or female hormones. DHEA at 1 to 200 milligrams a day is a treatment for rheumatoid arthritis, is a treatment for lupus in the traditional medical literature. And then, of course, we don't want to use it in patients with breast or prostate cancer. It does help to decrease the dose or reliance on nonsteroidals and deep marts. We mentioned excess estrogen in men. What do we do with that? We can measure estrogen metabolization. Indole carbinol has anti-inflammatory effects because it inhibits NF-kappa beta. Weight loss, estrogen is stored in fat cells in both men and women. So if people lose weight, excess estrogen will go down. People should avoid alcohol. Surgical correction of a varicocele in men will lower estrogen. Increased fiber intake lowers estrogen. Cruciferous vegetables like broccoli, Brussels sprouts, kale, and cauliflower. Green tea, they can drink 3 cups a day or take EGCG. Anastrozole in men can lower estradiol and raise estrogen. I used to use that a lot. In all honesty, I haven't written a prescription for years. Instead, I use Chrysin. Chrysin can be used PO or transdermally. Most people use it transdermally. It doesn't have any side effects. If the patient is on testosterone and you're using that transdermally, you can mix Chrysin and testosterone in the same syringe or pump. If the patient has low testosterone, androgen deficiencies predispose and exacerbate and contribute to RA. So writing a prescription for testosterone if the patient is low and they're a candidate for it will help with pain control and decrease inflammation. Testosterone is an anti-inflammatory in males. It does also decrease inflammation in women. It allows lower use of nonsteroidals. If the patient is truly cortisol deficient, then treat that. Usually we don't give steroids for that. We can raise cortisol in many other different ways if they don't have Addison's disease, with adaptogenic herbs, adrenal extracts, licorice, and people who don't have hypertension, etc. If they're hypothyroid, please treat that. Treating also helps with hyperprolactinemia. So if hypothyroidism is present, then make sure you look at toxic exposure as a cause of the autoimmunity. And of course, obviously do a gut health test. These patients do have dysbiosis. In my entire career, every patient I've had, everyone with an autoimmune disease gets a gut health test, including rheumatoid arthritis. I have never, ever seen a normal functional medicine gut health test. I just haven't. So a GI health test is really important. There's a number of companies that make good tests. Sinorespiratory dysbiosis can also be related to the GI tract. People can have yeast and or bacteria. Some of these people have small intestinal fungal overgrowth. They have this chronic sinusitis, etc. Even chronic prostatitis can be fungal. So some of these patients may need an antifungal drug for a couple months, like diflucan or nystatin. And then I usually also give them herbal therapies to get rid of fungus for another 6 months or longer. Also evaluate the GU tract. The patient can have GU dysbiosis. Proteus mirabilis is a candidate for microbial trigger in these patients. Proteus is increased in the GU tract commonly. So these people have evidence of immunological hyperresponsiveness to Proteus mirabilis. Look at chlamydia, mycoplasma, and look at all these others as well and treat appropriately, including yeast. Additional therapies, cat's claw has been shown to be effective in treating painful and swollen patients that have RA. And of course, if people need pancreatic or proteolytic enzymes, they can be very beneficially used as well. Devil's claw. You can get side effects from any herbal therapies, so I tried to put them on the slides. If you're not used to some of these herbs, probably most of you are. Devil's claw can be used. Willow bark inhibits prostaglandin formation via COX-2. Now, if the patient's allergic to aspirin or non-steroidals, then willow bark is not for them. Boswellia has great anti-inflammatory and analgesic effects. It inhibits 5-lipogenase and NF-kappa beta. Topical cessation can be effective as well. Anything that inhibits NF-kappa beta can be very beneficial. These nutrients do, so vitamin D, curcumin, alpha-lipoic acid, green tea, rosemary, grapeseed extract, propolis, and zinc. Zinc deficiency is common in patients with RA. As you all know, zinc is an antioxidant, and it is a cofactor for superoxide dismutase. So 45 milligrams zinc and copper do have to balance 10 to 15 milligrams of zinc to 1 milligram of copper, unless the patient has an elevated copper level. But again, these are nutrients that positively affect NF-kappa beta. Other nutrients, high dose selenium. I do measure levels of selenium. People can become toxic. I'm sitting here in Michigan right now. We are a low selenium state. Almost all of our patients can take on 200 micrograms. If they're from here, that's not an issue. Now, North and South Dakota are high selenium states. Most of those people don't need any selenium, but selenium levels do tend to be low in patients with rheumatoid arthritis. And selenium is a cofactor for glutathione peroxidase, which reduces prostaglandins that are inflammatory and leukotrienes. it is an antioxidant, but I do measure levels. Indole 3-carbinol, N-acetylcysteine, sulfur, resveratrol, pyridoxine. Some people do need pyridoxal 5-phosphate. These all positively affect NF-kappa beta. Glucosamine and chondroitin can help with pain control as well. Beta-carotene, burdock, copper, again in the right ratio. Magnesium is truly my favorite mineral. I love magnesium. It is a cofactor for 300 reactions in the body, and it truly is such a calming mineral. Calcium excites, magnesium relaxes. Molybdenum. Did we ever wonder what we use molybdenum for? It can be very beneficial in these patients. Pantothenic acid does tend to be low, and studies have shown that supplementation can help alleviate symptoms. Manganese SOD is deficient in these patients. Injectable form is used in Europe. In the United States, we use it PO. And of course, probiotics. If their gut's not healthy, are they going to use probiotics? Yes. I can't think of anybody in my own personal practice that isn't on 3 things: a multivitamin, fish oil, and probiotics. Supplementing with probiotics is immunomodulating. C-reactive protein improves. The patient's ability to walk improves as well with probiotics. And of course, curcumin, a great anti-inflammatory antioxidant. It inhibits the formation of leukotrienes. It's as effective in some studies as medications, 400 to 600 milligrams TID. It's usually formulated with bromelain to enhance the absorption. And for this purpose, should be taken on an empty stomach if you want to use it as an anti-inflammatory. Vitamin C. Vitamin C levels are low in people with RA. As we know, it is an antioxidant. It increases SOD, and it also reduces histamine levels. A lot of these people have high histamine, otherwise known as histodelia. 1 to 3 grams of vitamin C. Ginger, great antioxidant, anti-inflammatory. It inhibits prostaglandins, thromboxanthine, and leukotriene synthesis. The dose in India is honestly extremely high of ginger. Those are not typos, 8,000 to 10,000 milligrams. In the United States, we tend to use lower doses. And of course, fish oil has been shown to be effective. GLA has been as well. Blackcurrant seed oil containing 20% GLA in this double-blind study from 1994 worked great. Borage seed oil contains a little more than 20% of GLA. 2 studies have shown it to be beneficial. And the EGCG can be useful as well for both RA and osteoarthritis. Thunder God vine has been shown to be effective. Please don't use this though. The risk outweigh the benefits. I put this in just because you're going to see this in medical trials. It does work. Please don't use it. It can have serious consequences. Blenotherapy, the use of mineral baths and mud packs have been shown to have excellent results. Thorough wax root is used extensively in Chinese medicine. It's used with steroids. It enhances their effect. It also helps prevent adrenal atrophy caused by the steroids. It's commonly used with licorice root and ginseng because it can enhance the action they can of thorough wax. Niacinamide, vitamin E, quercetin, all the things that we mentioned for an NF-kappa beta are effective, obviously, therapies for rheumatoid arthritis, MSM, selenium, and pyridoxine. Sea anemone extract can be helpful. Rue shrub plant, yucca, bromelain, as digestive enzymes is the most common way. It does reduce inflammation. It activates compounds that break down fibrin, and it blocks the production of kinins. Phosphatidylcholine, it's what the cell membranes are made of. It's an anti-inflammatory that stabilizes the cell membranes. Newer research, though, is showing that we should always measure TMAO levels before supplementing with phosphatidylcholine or L-carnitine for that matter. About 1% of the world has a high TMAO level. Some people inherit it, some people it comes from the gut. But if TMAO is elevated, no red meat. These people should not eat egg yolks, should not supplement with phosphatidylcholine or L-carnitine. So measure TMAO levels first, then see if you can give phosphatidylcholine. Other treatments, therapeutic writing has been shown to be beneficial. And then, of course, physical medicine of cold packs, moist heat, paraffin baths, sulfur baths, massage, and exercise or range of motion in severe cases. So there really are lots of studies on all of these modalities. Acupuncture, one of my personal favorites, has been shown to be an effective therapy for rheumatoid arthritis. Tai Chi has been shown to be helpful as well. Yoga. Some people say there are no trials showing these. You notice that some of these are from alternative therapies, but many of these are from traditional medical journals, like Rheumatological Diseases of Clinicians of North America. CBD oil has been shown to be effective treatment. CBD is very interesting. It seems to work, most of us feel, in about 1/2 of people for different things it's used for, including rheumatoid arthritis. Unfortunately, as of date, there really is no test to show beforehand which patients it's going to work well in or not. Cannabinoids can modulate immune reactions in the periphery and the brain. They do influence T cell subset balance and cytokine expression and play a role in the balance between neuroinflammation and neurodegeneration. So the immune cells can synthesize endocannabinoids, and they can be influenced by the cannabinoid analogs. These receptors also show different expression on immune cells depending on activation status and stimuli. So cannabinoids are very interesting to look at. And of course, this talk is about LDN. We wanted to go through the breadth of what we could do from a personalized medicine approach, but it really should be highlighted by low-dose naltrexone. As we all know, naltrexone in regular doses is used for drug overdose. Low-dose naltrexone is compounded. It is not FDA approved, but then of course 1/2 of the drugs used in the United States are used what we call off-label. But LDN operates as a very novel anti-inflammatory agent in the central nervous system via action on microglial cells. It's very unique in the low doses. It seems to be entirely dependent on some of naltrexone's better known activity on the opioid receptors. It's not just on that. Daily oral dose, usually given at nighttime. It's inexpensive, and this study shows from clinics of rheumatology, very well tolerated. With age, the immune system does weaken and chronic inflammation sets in. LDN does reduce inflammation and pro-inflammatory cytokines. So in this study, it reduced plasma concentrations of all of those interleukins, interferons, transforming growth factor, TGF beta, tumor necrolysis factor alpha, and GCSF. So it's very anti-inflammatory. This trial from 2019 found that persistent LDN users had significantly reduced daily use of whatever medicine they were on. The results supported the hypothesis that persistent use of LDN reduces the need for medication used in the treatment of rheumatic and seropositive arthritis. So here's its effects of opioids on the immune system. As you can see here from the hematopoietic stem cell down, it does have effects on T17, Treg, Th2, Th1, and many of the other things that we've looked at as well through the lymphoid progenitor. Then you can see through morphine and down the other side of the pathway. At high doses, it inhibits TB and NK function. On lower doses, it stimulates these other functions. So here's the different mechanisms. It does increase endogenous enkephalin and endorphin, so it enhances immune function. It inhibits pro-inflammatory cytokines, so it's an anti-inflammatory. There is an interaction of the nuclear opioid growth factor receptor. It promotes DNA synthesis, so it has been shown to heal corneal ulcers. LDN also, you get a blockade of opioid R in the GI tract. Its effect on the liquid bowel movements, it heals and repairs mucosal surfaces. So it's been used in Crohn's, many other things, and it downregulates Th17, and it's just a fabulous anti-inflammatory. Are there potential side effects? There are for any drug that we use. In fact, today I had my hair cut and it was interesting. I got talking to my hairdresser and I basically said, oh my gosh, if you read side effects, nobody would take an aspirin. They wouldn't. So potential short-term side effects, insomnia is the most common. 30% of people get insomnia the first night. Traditionally, LDN is taken 1 hour before bedtime. By the second night, it goes down to 1 to 2%. If it persists, then we have people take LDN at 6 p.m. I have one patient who takes it at noon. People can get vivid dreams, fatigue, loss of appetite, nausea, hair thinning, mood swings, and mild disorientation. And yes, I have seen all of these. They are usually dose dependent. I'm going to talk about dosage in a second. Are there potential long-term side effects? Yes. Possibly liver and kidney toxicity, although honestly, I haven't seen it yet. Possible tolerance to the beneficial rebound effect. Haven't seen tolerance either. It is possible. There may be other unknown sequelae, but in some places in the world, it's been used for 7 to 10 years. Counterindications: acute hepatitis, liver failure, and recent or current opioid or alcohol ingestion. So absolutely, obviously, if it's used for a drug overdose, the patient is on opioids, they cannot use LDN. This is the most common dosage schedule. There's many dosage schedules. Anything above 6 to 8 milligrams is no longer low dose naltrexone. There's now micro dosing where people are using baby doses like 0.1 milligrams, et cetera. This is the most common. 1.5 milligram capsule 1 hour before bedtime for the first week. Then the patient takes 2, so they're on 3 milligrams for the second week. The third week they take 3, so they're on 4.5 milligrams. And then you compound a new prescription of 4.5 milligrams thereafter as a single capsule. In my personal practice, I probably have 10 people that are on 3 milligrams. I have a number of people that are on 1. I'm using it to treat COVID as well. Dosage depends on the severity of the disease. Anything that's inflammatory. Cancer, absolutely, absolutely. I know an oncologist that's actually using it prophylactically. All autoimmune diseases, weight loss, prevention of memory loss, treatment of memory loss, anything that's inflammatory, including rheumatoid arthritis. So in conclusion, as you have seen, there's numerous therapies for both a conventional and personalized approach to rheumatoid arthritis. LDN is a wonderful addition to that armamentarium of both a conventional and all the personalized medicine approaches that we have discussed tonight as well. Thank you very much.
Wow.
Wow. That's all I can say. Where do we begin? Anybody have any questions? What dose and type of cancer do you use LDN?
Actually, I use it on all my cancer patients I have on LDN, every single one of them. I love it. What dosage, the dosage is pretty much in cancer, the dose that I just gave if the patient is an adult. I don't see anybody under 16, so I can't answer doses for children. My friend who's an oncologist who's using it prophylactically is on 1 milligram, which I find very fascinating.
Okay. A little bit off topic, but in my experience, LDN over 3 milligrams in Hashimoto's thyroiditis, we usually start seeing some side effects. Any thoughts on that?
I think a lot of it has to do with clearance. You know, are they fast acetylators, slow acetylators? Some of it has to do with function. At 67, my creatinine is still 0.7 to 0.5, depending on how hydrated I am. I think it depends on how healthy you are, what you weigh. Certainly my patients that weigh 90 pounds, 3 milligrams may be plenty. Somebody who weighs 300, I have one patient who weighs 300 who's on 6 milligrams.
Okay, and as we all know, there's a commercial drug that has bupropion and I think it's 8 milligrams of naltrexone.
It is 8 milligrams.
Together in one pill, and in my experience, it's not done very well with it. But I don't know what anybody else, or if you've had any tried that at all.
I have not personally tried it. 8 milligrams would be a little much for me to try.
And then there was an outfit a while ago that was, I'm still new at this. Apparently, I'd like to unmute everybody if I could ask all to unmute. Okay, there we go. Using naltrexone pellets for weight loss. You know, any issue, any experience with that? Any yays, nays? Sounds crazy. I don't know.
Well, certainly pellet therapy is used for hormones. Could you
Right.
use it for LDN?
Oh,
you could.
No,
But I'm not a big pellet person, and this is a personal statement. Obviously, it's a procedure. So anytime you do a procedure, you can get an infection. If you get the dose wrong of whatever you're using the pellet for, you can't take it back. So that is one downside to pellet therapy, whether it's hormones, LDN, et cetera. If the dose is wrong, you can't get rid of it.
Well, we just deal with it until it wears off. That's all. Let's see, other questions. The dose for cancer, I think the question is it greater than 1 milligram, or do you taper up?
Yes.
To higher than
Usually
1?
for cancer, it is 3 to 4.5 milligrams.
Okay. And when you start at 1.5. Would you ever start at lower?
I do. For my patients who have just plain COVID, I give 1 milligram. For my patients who are, more severely impacted or my long haulers, I commonly have 3 milligrams, 4.5 milligrams. It depends on the severity of the disease when we're looking at things like COVID.
Okay. And can you comment again? I know you mentioned it briefly. There's a use for mini doses. I've seen micro doses, 0.1 milligrams, 0.2 milligrams. What is that being used for?
Some of it is being used in children. Some of it is being used in adults, really just because of side effect profiles. Most people, can tolerate 1 milligram. Some people can't. And so you can go down in dose when people, get side effects. Certainly if you're going to use it prophylactically to prevent memory loss, for example, 1 milligram would be plenty. A 0.5 milligram would probably be fine.
Okay. Good. Okay. Well, thank you for that. How about the person that's sensitive to everything? Would you start at a half? Well, we just answered that. Would you start it at a 0.5 milligram?
Yeah, and for people who are sensitive, start low, go slow. There's a new study that just came out on LDN and diabetes. Diabetes is an inflammatory state. People end up needing less medication.
And what about the transdermal naltrexone?
I love transdermal naltrexone for diseases of the skin, psoriasis, atopic dermatitis, even acne. Acne is an inflammatory condition. Any inflammatory skin condition, I love using it on the skin.
Okay. Anybody else have any other questions? If not, I'm going to ask you a couple more myself. I don't mean to monopolize everybody.
Well, let me add to the comment on the skin.
Mhm.
I do put it in the base Zematop. If you're not familiar with that base, it starts with an X, Zematop, T-O-P, X-E-M-A-T-O-P. And the reason I put it in Zematop is because that's an anti-inflammatory base. So I'm going to use I don't want to use a base that's inflammatory and put something anti-inflammatory in it. It would make no sense. So I put it in Zematop. It works better.
Okay. On the topic of naltrexone, but a little bit different. At another outfit, I gave a talk on post-finasteride syndrome, which kind of morphed into a medical hair regrowing. Came from that, and we started looking at different compounds to put together to use, on the scalp, either topically, and of course there you can use like finasteride and minoxidil. The idea is that the balding scalp is now has fibrosis and is inflamed. Have you ever had any experience mixing in naltrexone, like a 1% naltrexone with that?
I have, and it's recent, so I haven't seen the patient back yet. So I'm happy to let you know, Bill, what I find.
Okay, let me know. And any experience with LDN for autism?
For autism, it is used in autism. I don't see autistic patients. Some of my partners do. I have one patient who specializes in autistic children, but we do use LDN for that, yes.
Okay, and I do too. So I see some autistic kids. Just as a little heads up, high growth hormone, low IGF-1, and high testosterone levels we find in these kids, depending on their age. And topical LDN seems to work quite well for the behavioral issues there. So at least in my experience.
And we use it for ADD as well, anything really on that spectrum.
Okay. Okay. Anybody else have any questions? You must, there must be some here. Dr. Burgess?
Yeah, I have a question and just want to give a warning to Dr. Smith that several of our members in our small group have been trained by you, Dr. Smith, with A4M and other places. And you're so good at what you do. We want to keep an open offer of for you to lecture, if you will, if you can, if it's convenient, at our national OMED meeting, which is in October. And what we're trying to share is basically what you have taught us over the last 10, 20 years. I don't know how long. So.
Well, send me on over the information. If I'm available, I'm happy to look at it.
It's in Phoenix this year. It was the same one we went to when I dragged you to Philadelphia that time. It's the same crew. So we're better known now. The last time it was live, they put us in a room with that of 60 people, and they were standing room only, sitting room only. They had to move us. I think we had 600 out of like 2,500 doctors, and we're the little nobodies. So if we can get our moniker changed, this week is the House of Delegates there. So I'll be banging on doors. Unfortunately, it's online, so I don't have to go to Chicago, which is a place I really dislike. So let's see. Anybody else? I don't have any more questions in the chat room.
If anybody else has any other comments, questions, this is a treat to have Dr. Smith with us. She's really one of the superstars in the anti-aging world. And the fact that we got her here is a real bonus for us. So we do record it, and we have on our website, we put it up with the slides if that's acceptable to you.
It is, absolutely.
And we are here every Tuesday night if you have nothing else to do at this time at 8 o'clock. We spend a lot of time talking about COVIDs and cytokines and methylene blue. Or Dr. Hala, I don't know if you know Dr. Halasi. He's not here tonight. I think he's in Germany or in Turkey or something this week. He's our resident nanoparticle expert here. So there was one question about CBD, I missed that, and THC. Can you use a THC and CBD mixture for the cancer patients? I think that was what the question.
Actually, most of the studies have been done on straight CBD itself.
Mm-hmm. Okay. Okay, so with that, was short and sweet tonight. Thank you so much. We really appreciate it. Again, anybody have any questions, comments, anybody who wants to give a presentation, please let us know. Dr. Smith, we can't thank you enough as always, and keep me in mind for A4M,
Absolutely. Thank you for the opportunity.
Okay,
everybody.
no, thank you.
Take care now.
Okay, thank you. Good night.
Be safe, everyone.
Okay, thank you so much. We will be back next week, same time, same station. We have Dr. Patel will be giving us her update on her COVID nanoparticle treatments. So she's had some remarkable successes. We've been talking back and forth on, I don't know, one of those telegrams, or one of the what's the other one there? Not WeChat. There's another one. It's got a green symbol. I can't think of it now. So thank you all for coming. Please bring somebody with you so that we can grow our audience here. And if you have any questions, comments, you can get me. Here's my email. Here's my cell phone. You can text me. You can call me. We're on the West Coast, so 570. That's the wrong phone number. 570-881-6821. That's the right one. Okay. Anybody have any questions, issues, problems? Please let us know. If not, we'll say good night, and we will see you next week. And good job, everybody.
Thank you, Bill.
Thank you. Thank you, everybody. Thank you, Brad, Dr. Chin, Dr. Ardello, Dr. Denise, RKC, whoever you are, Kent, thank you for showing up. Dr. Spear, Dr. Stoker, RKC is a new name, so thank you for coming with us. Marie Fogarty, thank you. And we will see you all next week. And we'll have a good week, and do good work and be good humans also. Okay. Good night.
Hoorah.
You're